Hey, Rod, good afternoon.
Good afternoon, Sonabo. Good afternoon.
You know,
Very
I
well.
nearly
Welcome
said,
to you.
I nearly said, hey, good morning. I forget every time me and you meet in the afternoon.
Absolutely, absolutely. The
But
morning is for really a lot of grave digging and fixing what we have to do, and the afternoons we can actually engage with our audience at large.
tell me something very interesting. You know, don't you think that this Tuesday they fly? You know, it's like we met day before yesterday.
Exactly, that's true.
You know,
Tuesdays
when
are
we
it's
had
probably
Advocate Lufuno.
it's probably because we had a public holiday and we had a long weekend, and now suddenly we're back on Tuesday again. But
Yeah, but
it is flying.
it is, it is. And today, Aish, we've got a very interesting discussion that that you bring on board on, anything to do with health. It's a very interesting topic, post-COVID and all the challenges that we have worldwide on health related things and health matters that are caused by environments, different environments that we all know what's happening worldwide. But let's focus in our country and say
Absolutely.
where are we, have we moved from pre-COVID, during COVID, now that we're in post-COVID, has our health environment changed? And I'll tell you why I'm asking this question. You know, lots of environments and lots of sectors have progressed speedily. You know, some of them at an alarming speed, where people have adopted technology as a way forward in coping with their environments and doing business. And some of them in addressing challenges in their client's environment. And basically, sectors are not the same as yesterday. We are looking at a
Absolutely.
different thing, and it will be very interesting to hear from you. Where are we when it comes to health?
Absolutely. I'm going to try my best to actually share with the audience the expertise and knowledge and the skills that I have, respect from an ICT base or technology base, and how the health sector can either benefit from them, what is the barriers, and obviously where's our position. So I will sketch the playing field, or I will really give you the lay of the land in terms of where are we in terms of health, what have we done,
Yes.
how have we progressed. By the way, COVID is not done yet. COVID is still very much alive. We still have cases daily. It's just in a more controlled manner. So COVID is going to be here to stay for a while, a little bit longer. We will relax in some of the other aspects of health, but I'm not going to be so brave to say COVID is over or post-COVID period. COVID is still here. It's still alive. We still have the 1.5 meters social distance in the supermarkets, still wearing your masks, washing your hands, and doing all that's necessary to protect you and your loved ones.
Thank you. I hear you. I hear you. I hear you. Now, can you share with us? And look, take it that there's people that are listening who don't understand how technology enables or impacts positively in the health space. If you can give us a broad understanding of what are we talking about, where is the discussion going, and what needs to be done in areas where we've not done such.
Okay. All right. Thank you very much, Sunabo. Once again, thank you very much for our audience. I know that we live streaming on YouTube, on Facebook, and also on Twitter. And some of you are actually listening on our Pan African radio station as well. I am not going to talk about the Cuban doctors that are in the country. I'm not going to talk about the dire situation that we have currently at Chris Hani Baragwanath Hospital. I know it's probably a subject that you would like me to talk about, but I'm not going to share about that. I'm not going to talk about the damage and the burn and the destruction we had at Charlotte Matlake Hospital as well. And I'm not going to talk about those 800 plus medical health workers that are now being laid off because they were on a contract basis towards COVID. So I'm not going to go into those crucial or difficult discussions. Instead, I'm going to talk about the context of healthcare market in South Africa. I'm going to talk about South Africa's burden of disease. I'm going to talk about some of the landscape and some of the other areas that we're actually doing for that. So that is actually where I'm going to focus on in my introduction. So,
Okay,
Nabo.
Rod, I think I was just waiting for you to warm up. I wanted you to little bit warm up. I think it is only fair to tell people that are listening and people that are going to be listening, who Rodney is. People have got a tendency of starting a recorded thing and jump to the middle and jump to the end. I
Okay.
think it's strategic for me to deal with it at this point.
Of
Now,
course.
Rodney is an advisor, and he fits within the panel of advisors within PICTA. He plays a very strategic role in giving the president of PICTA, which is myself, support in terms of business development, in terms of strategy and positioning of PICTA in the industry, and ensuring that we understand how we need to engage with the industry. Okay, he's got a very good understanding and experience of the public sector space. So he is quite rounded. You find people that are on the private sector, you find people that are on the public sector. He's got the most critical sectors or experience in those sectors. He is an independent consultant. He decided to go fend for himself and leave corporate. He's an independent consultant, specializing in in few areas in the sector. So he's a subject expert, or subject matter expert, as they normally say, in strategy and in technology consulting. If you need anything to do with or advice on technology, you need advice on strategy, you need advice on cybersecurity, you've got an environment that you're not sure of what's happening, Rodney is capable and willing to come and do an audit of your environment and tell you how your environment looks like. And I'm going to mention this, Rod. I was really shocked over the weekend that the people who keep our credit scoring, they've been hacked, and the hackers wanted to release all information concerning the big banks.
My goodness. Well, it's
Okay,
not the first time that our credit bureau has been hacked. We know the last time what happened with
I
Meridian.
look, it's you that is mentioning it. Me, I was only willing to say people that keep our credit scoring, but they've
Okay,
been
all
hacked.
right, good
They
enough.
want 200 and something million. Okay.
Sure.
Anyway, let's leave that. We're not in cyber today. Let's continue, Rod. Please walk us through. Let's have a discussion, and then we can ask questions once you've given the flesh of the intro.
All right, fantastic. Thank you very much, Nabo. By the way, everybody's welcome to actually, if you have a question or a query, or you want to have a message, please utilize any one of those platforms. It's available there. And if you want to maybe have an offline discussion, we can also engage in that respect. So Nabo will provide those details. Let me give you the context of healthcare market in South Africa. When we talk about healthcare market in South Africa, we are compelled to focus on more detail on what we call the burden of disease, the structure of the
Yes.
healthcare system, the regulatory framework, and the potential future developments in healthcare policy. Now, in South Africa, healthcare is provided through what we call a highly unequal two-tier system. The private sector accounting for more than 50% of the country's total expenditure of the healthcare, while providing care to just 16% of the population. I'm going to say that again. Healthcare in South Africa is provided through a highly unequal two-tier system. The private sector accounting for more than 50% of the country's total expenditure on healthcare, while providing care to just 16% of the population. This is due in part relatively high cost of the private healthcare. Medical aid cost is very expensive, high levels of income inequality in our country, and the limited number of individuals covered by medical aid schemes. The public sector, which accounts for less than half of the country's total healthcare expenditure, services the remaining 84% of the population. Let me say that again. The public sector, which accounts for less than half of the country's total healthcare expenditure services 84% of the population, and a large proportion which accesses to free primary healthcare are delivered through nurse-led clinics. Yeah, I'm talking about the townships, the peri-urbans, some of the rural areas. There are very few or sometimes no doctors. These healthcare centers or clinics are led through our nurses. So it's important to understand that there is a very high proportion of our population that has very limited access to the best medical healthcare that there is. So in some instances, it's like a tongue and twist, because here we're talking about the healthcare technology, but yet we have a highly unequal two-tier system where a small percentage of our population are enjoying the benefits of private healthcare. But we'll talk through that. Generally speaking, for profit sector is well sourced and caters for a population that tends to be wealthy and urban and more likely to be formally employed. That's when I talk about members of our society that can afford medical aid. In contrast, the public sector, that's the everyday or the majority or the major portion of our population. Public sector cater for majority of South Africans, and it's challenged with fewer resources, both in terms of health professionals and equipment and infrastructure. There are challenges. There are big challenges. We must illustrate the different models of care in the private and the public sectors. The public sector is dominated by a large number of public clinics and community health centers and smaller numbers of hospitals of different sizes. So that is maybe a very bad introduction to tell you first the bad portion about it. And then in contrast, I want to tell you about the technology that can be used to actually make our life a lot easier. In contrast, the sector is dominated by acute hospitals. This is now the private sector or the medical aid hospitals, and you know who they are. They're followed by day clinics and subacute facilities. Notably, private general practices are excluded from comparisons. However, it remains fair to say the model of care in private sector is the model of care for private sector is more attractive, and it's centered around primary care. And this is obviously the stats that's given to us through from Stats SA and from general practitioners. I want to share, maybe I want to pause there for a moment, Sonabo, just to see if there are any. I see there's maybe somebody that's trying to get hold of me, but I think maybe they'll try and get online. But I want to talk now about the burden of disease, South Africa's burden of disease. Our country's burden of disease refers to the assessment of mortality, morbidity, injuries, disabilities, and other risk factors specific to the country. And South Africa is unusual in carrying a quadruple disease burden. Let me say that again. A country's burden of disease refers to the assessment of mortality, morbidity, injuries, disabilities, and other risk factors specific to South Africa. But we're carrying an unusually quadruple disease burden. Yeah, I'm talking about poor maternal, newborn, and child health. Communicable diseases, including tuberculosis, HIV/AIDS, that are very costly to treat. Prevalent non-communicable diseases, high rates of violence and injury, and obviously the COVID-19 pandemic. So historically, a typical country's disease burden is transition as incomes grow from one of infectious diseases, a high child mortality, malnutrition, to a predominance of degenerative chronic diseases. But increasingly, however, developing countries are experiencing a double burden, resulting from the simultaneous occurrence from communicable and non-communicable diseases. In the case of South Africa, there's an additional problem. It's called the high rates of trauma. So South Africa's disease burden is markedly different to other income countries, such as the first world countries, Europe, USA, certain parts of Asia, specifically an analysis of disability adjusted life. That's what the World Health Organization calls it. It calls it disability adjusted life years. It's a measure of the future stream of healthy years lost to each incident of a disease or an injury. And in South Africa, those diseases that was hitting us was tuberculosis, was HIV/AIDS, and other injuries make up a larger portion of that total disease burden. So we, in absolute terms, If we want to talk about South Africa's burden of disease, South Africa has higher quantities of ill people per capita than other comparable countries, including the BRIC nations, Brazil, Russia, India, China. If you just have to make that assessment to that. I'm going to pause there for a little while, Sonabo, just allow some of our audience just to chew on that and afford you maybe just the time just to pause if you have questions and queries on that.
Okay. No, I think for me, it is, I'm going to ask questions at the end. I
Okay.
think we need to give you time and space to be able to say as eloquent as possible on deliver
Okay.
your your facts.
Fantastic.
But I think also, Rod, it's very interesting that Palta is putting, is putting so much into our community in terms of how much we disseminate information,
Okay.
and this is why it was created in the first place, or established to disseminate such information, which is very pertinent for everyday life of people. There's a lot of things that we take for granted, and people are focusing on COVID right now, but there's still things like tuberculosis. There's still
Yes.
issues, or diseases like AIDS.
Yes, absolutely.
And where are we, and how can we use technology in moving forward in addressing such challenges that we have?
Fantastic. Fantastic.
Issues of people going to hospital and they can't find a file, where they're
Yeah.
still using where they're still using paper, and
Right.
why in this day and age they're still using paper. An ambulance pitches up to come and collect a person. There's no record of a person. They can't administer any any medication in trying to stabilize this person, because one, there's no record. They don't even know if this person is allergic to any medication.
Mm-hmm.
You know, in this
It's
day
called
and
the
age,
first. It's called the first alert care.
yes.
In the
So
olden days, or sometimes even up to now, people carry a bracelet to say, "I'm allergic to penicillin" or "I'm allergic to particular drugs." It's what the paramedics normally do when they get you into the ambulance if they finally arrive, just to actually do the first line care, just to make sure
yes.
to establish and stabilize the person, stop the bleeding, or maybe get him to a conscious state or her to a particular position where they can be transported. Yes, I agree with you. But let's continue.
Yeah, let's continue, Rod.
Okay, now when we talk about medical technology, the current market for medical technology in South Africa is still dominated what we call traditional devices. It is estimated that 90% of the medical technology currently used in South Africa is imported. So combining this figure with imported data suggests that the market for imported technology, ideas, and equipment that we actually get is close to about 400 billion every year. Now, just
You,
before COVID, we had a figure of 350 billion rand, South African ZAR, that was spent on importing traditional devices from other parts of the world into the country. So 90% of our technology that we use in medical field or the medical industry in South Africa is imported. So the value of imports reached a very high level in 2018, 2019, just before COVID, but that compared to the 2.6 billion of exports. And now it's very important to say that this does not include services and software, which comprise an increasingly important proportion of health technology. As such, the market for health technology is, in its broader sense in South Africa, to be estimated in an excess of about 400 billion annually. That's what they actually do. I'm quoting here from Department of Health and also from Stats SA and the World Bank, World Health Organization figures for 2019, 2020, 2021, and 2022. So the majority of devices and technology is imported from the States, United States, which supplied 28% of total imports over the last 10 years. From the United States, then we have Germany and China, 14 and 15%, 14 and 9% respectively, and total imports from 2010 to 2019. Other importers that we buy from, countries that we buy from, includes countries like Switzerland, the United Kingdom, and Japan, even Netherlands. The Netherlands supplies about 3% of the total medical devices and technology to South Africa. And that is quite a big portion. So the type of medical devices that we import into the country, and this is leading on to my topic of discussion today in terms of how digital and the health technology that we can utilize or benefit. The devices that we import are medical instruments and devices, orthopedic appliances, electronic imaging devices, therapy devices, breathing devices, and microscopes. Those are the type of devices that we currently import. And like I said, 90% of all these medical technology devices we import into South Africa. I want to now just sketch for you, because according to World Health Organization and from Department of Health, health technology is the fourth component of health provision, along with health practitioners, facilities, and pharmaceuticals. So when I say health technology, I talk about both medical devices, from relatively simple such as syringes and swabs, to complex high-tech devices such as MRI scans, medical technology, basic software, artificial intelligence, and machine learning. So it's important when they say health technology, what am I referring to? What are the basic stuff, the relatively easy stuff, such as syringes and swabs, etc., to some of the more extravagant, more sophisticated devices like our magnetic resonance imaging scans, those type of things. But I want to focus, and I think it's important that I paint the picture of the four of the most important groupings of health technology. First one is what we call data capture technology. This is, and you mentioned it earlier, electronic health records. Very important. Electronic health records. That falls under data capture technologies, enabling sharing of patient data between points of care. Do you know, and it still happens today, where somebody gets on the taxi or on the bus and go to the general hospital in Pretoria, the main hospital. Then they actually go sit in the queue, wait for their file to be drawn, get their file, see the doctor. The doctor gives a script, goes to the pharmacy in the hospital, picks up the medicine, but leaves with the script, or takes that same script and go home and actually go to another pharmacy and have it dispensed again. Because there's no data point or sharing of data points between certain points. Some instances it's actually happening. You know, we're doing it now through some of the more private healthcare, but at the moment that's a big problem. Electronic health records is a problem. If your docket is missing, you must go to the hospital at 3 or 4 or 5 in the morning, stand in the queue until the office opens, and then wait for your medical docket or your medical records before you can get treatment. Secondly is routine health management. That is web-based surveillance systems, electronic disease registers, and electronic district health information systems. So here I'm talking about data capture technologies are one of the areas that we would benefit through healthcare technology. The first one is electronic health records. The second one is routine health management information. And the third one is what we call vital registration. The use of computerized systems for the registration of deaths and of births. Vital registration. Second point is communication and knowledge transfer technologies. Here I'm talking about health knowledge management, like best practices based on guidelines managed and assessed electronically. You'll actually see it, and a lot of times we actually watch it on television or watch it in movies where a doctor somewhere in the DRC or somewhere in Guguletu or some of those areas actually does an operation whilst looking at the video. So they actually do health knowledge management through all of these mobile devices like mHealth. They actually do mobile devices, their cell phones, to share information and to collect and aggregate of patient data. Another area is telemedicine. That's the use of ICT to provide care at a distance. I know that this is something that we spoke about for the last 10 or 20 years in terms of telemedicine, but we haven't really exploited or taken advantage of this ability to be able to provide care at a distance. That is telemedicine. Mobile care, virtual healthcare, example, teams of professionals working together via ICT networks and communications. That's another aspect. The third area that I think we can benefit out of this is what we call consumer health technologies. Consumer health informatics, it's information that's accessed on health by healthy individuals or patients and the wearables there that goes alongside with it. And the last point I think we can focus on the grouping of healthcare technology or medical technology is artificial intelligence and robotics. That's healthcare provision in South Africa is split in what we broadly categorize as well-funded private sector and a resource-constrained public sector. Both these sectors present potential markets for health technology products, with some overlap and some differences in these types as well. But Sunabo, as in everything, there are barriers. There are barriers to technology. And there's some barriers that I want to share. There's probably about half a dozen of those barriers. And some of our audience would probably attest to that or can testify to that. But there are certain barriers to everything. But in healthcare technology, these are some of the barriers that were highlighted. First one is regulatory constraints. Regulatory environment presents a consistent challenge across the industry. The Health Professional Council's ethical rules for members played a large role in preventing the expansion of telemedicine. We just spoke about telemedicine a while ago, where we can actually do patient healthcare from a distance. But the Health Professionals Councils, the ethical rules for members have played a serious role in preventing the expansion of telemedicine. While the medical device spaces, the certification and backlog of South African health products regulatory is the most significant issue. User resistance. The success of many of these technologies depends on the level of adoption by either the health professional or the patients or the consumers, or in many cases, both. There's a high reluctance to move to new ways of doing things. It's a serious problem. I remember many moons ago when you have a cough, there used to be the Lennon's cupboard. I don't know if most people will know what is the Lennon's cupboard. Die harlemensis and die borsdruppels and die versterkdruppels and die
Us were
roeipoeier.
born in the Stone Ages.
Yes. So there's a reluctance. There's a reluctance to adopt these either from the health professionals or even of the consumers. And I don't want to mention, we once had a minister of health many moons ago that promoted garlic and beetroot and some of those areas. I'm not saying those herbal or health products are wrong. They do have a place, but that there is a high reluctance and a high resistance to either adopt these health professionals and consumers. The third one is financing constraints. The implementation of new technology often involves very substantial financial investments, which result in costly savings only from being realized sometime down the line. So it is a problem. It is a fact. There is a financial constraint. So in today's difficult economic environment, lack of available financing acts as a serious constraint in both the public and the private sector. Another constraint or a barrier to implementing this technology is the lack of appropriate solutions. Many people struggle to find technologies that were able to meet their particular needs or were appropriate for specific South African people or the public. Let me say that again. The lack of appropriate solutions. Many interviews struggle to find technologies that were able to meet their particular needs or that were appropriate for us, the South African public. Another one which we are very familiar with is what we call the bureaucratic decision-making. Protracted decision-making processes are an issue in both the public and the private sector in South Africa. I will say that again. Protracted decision-making processes are an issue in both the public and private sector in South Africa. This can make the sales cycle for new products, especially new technology products, very long, especially when the required financial investment is large, or the innovative nature of the product means that the resulting benefits are uncertain. So those were some of the main, what we call the barriers. Regulatory constraints, number one. Number two, user resistance. Number three, financing constraints. Number four, lack of appropriate solutions. Number five, bureaucratic decision-making. So those were the five big barriers. There are probably many more. I'm sure there are plenty, a whole long list full, but I thought, let me just highlight those for you for a moment. Let me just pause there for a moment, Sonabo, if there's any comment that you want to add on it or any questions that you receive online.
I've not received any questions online, Rod.
Okay.
But I hear you that there's constraints. And in you addressing or me wanting to understand, for the rest of the people that are going to be listening or watching this video afterwards,
Mhm.
you know, bureaucratic red tape, financial constraints, regulatory constraints, those are elements. And I've put financial purposely. Those are elements within the public sector space that government can can address immediately. Bureaucracy, it's very strange, and it's very interesting in that there's some items or issues that when they need approval, it does not even take a month. There are things that impact on people on the ground that will take a year, will take 3 years, okay? Or it can even take 5 years, okay? They happen because elections are going to happen.
Okay.
But
Okay.
and this is not a political platform, as we all agreed. But if we look at how much Gauteng Health owes the suppliers, if that 3.1 billion one was spent on the technology to make a difference on the ground, as you are informing us what is needed on the ground, I would understand. Okay.
Okay. Okay. Gotcha.
Um,
Gotcha.
and for me, we really there's is and I'm asking a question: is it a willingness? Is it ignorance? Is it not caring? It is unwillingness. Is
Mhm.
it an issue of not having the capacity or capability within the country for us to be able to to innovate appropriate solutions that are meant for South Africa?
Okay, I like that. I like that, Sonabo. And what I did, however, while the obstacles and the barriers are quite significant, there are also strong dynamics at play. And I want to share
Yes.
probably three dynamics that's at play that will drive growth in the health technology market. And these are three key trends that will create demand for health technology going forward. The first one is what we call the consumerization of healthcare. Consumerization of healthcare. While conservative cultures may mean that disruptive changes will not be inundated proactively by providers, providers will come under pressure from consumers and patients to act.
Okay.
Consumerization of healthcare. The providers will come under constant pressure from the patients and the consumers to act. It's very important, and especially our millennials. Our millennials of today are very active. They're very knowing what they want, and 65% they will not engage with a healthcare provider unless they can book an appointment online. Just to give you an example, they want to be able to book online. So, in other words, the technology needs to be available because if they can book online, they have a secure booking, they have the right time, they can manage their lives, they can do work life balance, they can do obviously an area that if they want to know healthcare, I'm not going to spend 4 or 5 hours. I know I'm going to spend 2 hours or 3 hours. So, there's a high percentage of pressure that's been put on these healthcare providers. So there are huge opportunities in the market for technology which connects patients, consumers, and providers. So that's the one aspect, which are obviously something that drives. Although the obstacles are high, they are significant, the barriers are strong, and they're heavy, there are some key trends that will create demand for that. And the first one, consumerization of healthcare. Second, the pressure to reduce costs. There's intense pressure to reduce costs across both public and private sectors. So what I'm saying here is the potentially huge financial returns available to technology companies to enable healthcare providers to reduce costs that attract the big investors in the healthcare space. It's important to do that. And we see guys like Jeff Bezos at Amazon is doing that. We see even Warren Buffett from Berkshire Hathaway is actually doing it. So there's huge returns for these providers because the investors are looking towards that. And the third one is the increased focus on outcomes. There's a growing recognition that healthcare purchasing must become more value-based, with a much stronger focus on the outcomes of healthcare delivery. There is a growing recognition that healthcare purchasing must become more value-based, with a much stronger focus on the outcomes of healthcare delivery. The resulting need for technologies which will enable outcomes measurement and facilitate more integrated care across pathways will be a significant driver in this growth. So while these trends will drive demand, many of the companies that are involved in here, you can call them often by name. The healthcare companies we have at private and some in the public, particularly in the healthcare administration sector, report that they're busy buying software off the shelf and prefer to build their own in-house solutions. But the underlying for this preference is the bespoke software. So in other words, the technology of the healthcare, that's why you see the Oracles, the IBMs, the Microsofts, the AWS, the software AGs, all of these companies are pushing towards that. The Sage, these companies they're building their solutions around that. So in this big dark cloud of all these inhibitors and all of these barriers that we have, there is future and there are trends in healthcare technology for South Africa. I hope that answers your question.
But Rod, is it moving to a better digitized health environment for the privileged, for the urban areas, or is it for everyone in South Africa?
I'm glad you asked. That's a
And
very.
I'm sorry.
You're putting me on the spot there.
And I want you to. I want us to address this one.
Okay.
Do you know that, Rod? I'm going to make an example where I come from. I come from Herschel, in a place called Kovo. 40 kilometers away from where I come from, there's no doctor. Okay? I'm 40 kilometers from the nearest doctor. Okay? And that doctor does not work. Even the public hospitals don't work like it was a long weekend. Are not at work from Friday end of day until today. They start working on a Tuesday. So if there was a means for such areas, and I want these, now that you've mentioned IBMs and all those things, what can they do to link on your e-health system? Sometimes a person just needs an online consultation like we have in the urban areas.
Exactly. That is one of the big push that technology is actually giving us the edge. Technology is making it available. And these big multinational companies, they've seen this long time ago. They recognized the need a long time ago. Hence the reason for telemedicine. Hence the reason for rural telephony, to be able to make sure that we can actually reach those areas. Like I said earlier in my introduction, a lot of these outlying areas, like in the township or the peri-urban or the rurals or the farmlands, or these areas, the healthcare facilities are run or led by nurses. And if we make available this software or the technology or the solutions via mobile, via video, via web, there are various aspects that can be made available. Hence, that's the reason why a lot of pressure is now put on the providers for that. But more importantly, also our big stakeholder, which is government. And government wanted to level the playing fields in terms of healthcare affordability. And there was this, I don't know if it was manna from heaven in terms of national health insurance, or if it was a dead duck in the water because it wasn't maybe properly worked through or not all stakeholders were engaged in it. But I have some information on regards to the national health insurance and how it can be another dynamic in the South African market and its introduction to create some opportunities, but it can also create as a threat. You understand? So yes, the AWS and the Oracles and the IBMs and the Informix and the software Gs and the Siemens and all of those multinationals and all of those investment companies, those investment houses, such as the Berkshire Hathaways that I mentioned, the Jeff Bezos, and a lot of these guys, even our own Pretoria boy, Elon Musk, they all dip into the area in terms of healthcare technology because they know the benefits. They know how it can improve the life and the livelihood of a lot of people. But there is what I said earlier, there is some of this resistance. There is the financial constraints. There is the unequal balance of a two-tier healthcare system, private and public. And importantly, very importantly, is the affordability. You mentioned it. You're 40Ks from a doctor that takes weekends off. If you get a toothache on a Saturday night, you're going to have to take a lot of ginger and grandpas to put it there in your mouth because that doctor ain't coming around. But if you actually had used the technology, be it video or mobile or some of those other technologies that's available right now, through 4G or 5G technology, it's available. Then it could have made our life easier. But I want to talk about maybe the National Healthcare, NHI, and see if this can be an opportunity or a threat. The opportunities will be seized by companies which are able to scale up to meet the challenge of delivering on the national footprint. We have a few thousand hospitals around the country, private and public, mostly the public hospitals. So the opportunities, it will be seized by those companies that are able to scale up. I mean, Nicholas Crisp, who was the guy that was responsible for the NHI fund, has emphasized the need for evidence that solutions can work at scale. So firms will need to demonstrate that they have a model that's already working in a country such as Africa. And many companies are trying to do this at the moment. So they're well positioned to bid for some of those NHI contracts. Do you know that the National Health Bill was published in August 2019? And if and when it's implemented, it will bring a significant change in the way healthcare is provided in South Africa. The bill envisions a single national health system where the NHI fund becomes a single buyer of healthcare products and services from both public and private sectors. That's a very important point. Let me say that again. The National Health Insurance Bill was published in August 2019. If and when implemented, will bring about significant change in the way healthcare is provided in South Africa. The bill envisions a single national health system where the NHI fund becomes the single buyer of healthcare products and services from both the public and private sectors. And that's probably the most controversial aspect of the bill is in Section 33, which limits the role of the medical aid schemes. It restricts them from offering what we call complementary cover to services not reimbursable by the fund. So the interpretation of this clause continues to be widely debated. But if strictly interpreted, it would mean that the end of medical aid schemes in their current form will potentially serious implications for private sector providers as well as the public sector and the public sector if it's not replaced by the NHI funding. Very important. The bill also stipulates and provides for the creation of the Office of the Health Procurement Products, which will be responsible for, among other things, the procurement of health, technology, and equipment on behalf of the fund. Let me say that again, because that's a very, very important point. The bill, the National Health Insurance Bill, the NHI bill, provides for the creation of an Office of Health Products Procurement, which means they will be responsible, among other things, for the procurement of health technology and equipment on behalf of the fund. So there's a long list that the Office of the Health Procurement must determine the section of the health product, develop a national health product list, coordinate the supply chain, facilitate the cost effectiveness, equitability, appropriate public procurement, support the processes of ordering, establish mechanisms to monitor and evaluate the risk inherent in the public procurement process. And we know the story. We saw what happened with the PPE tender fraud. Those are some of the things that we have to think about. So while the private sector providers are envisaged to remain in operation, providing services to the NHI fund, the public sector would become a more significant buyer of medical technologies through the Office of the Health Products Procurement. That's the big big, big contention at the moment. And this would increase the importance of compliance for health technology supplies, depending on the level of funding made available to the NHI fund and the speed and success of implementation. But at this stage, right now, today, on the 22nd of March, 2022, there's still much uncertainty surrounding the detail of what NHI will look like, whether the plans will be able to put into practice. But in any event, implementation is likely to be slow to both the public and the private sectors, and will continue to operate largely as they do for now, for at least the next 5 years. I don't see the NHI actually taking effect. It's been around, since it's been spoken about and on the table since 2019, but another 5 years, that's more than, it's now, well, it's nearly 3 years when the bill
Rod,
was published, but it's still
well,
another 5 years, I think.
Rod, well said, but government has failed up to this point to consolidate the IT procurement environment for government, okay? For them to get discount on procurement for government, for them to ensure interoperability, to ensure that the environment is efficient and it's well managed. How are
Mhm.
they going to master procuring for for health sector?
We need to first clean in front of ours. Before I answer that question, I see there's a question from Inam that says she can relate to what you say. She's from a place called Kaleni, and she wants to know, would I be able to benefit? Ngeleni,
Yeah.
Ngeleni. She wants to know, will it be able to benefit from this, especially in a place with low network coverage? I must mention to Inam that you obviously know, or you've seen, that MTN, Cell C, Vodacom, Liquid Telecoms, and Telkom, 6 companies bid for what we call the spectrum. And MTN bought 100 megahertz, Vodacom bought 110 megahertz, Liquid, Cell C, and Telkom, and some of those other players, they all bought some megahertz. This will allow us as the consumers the ability to have, once they expand their 4G and their 5G network, the coverage will be a lot bigger. So the footprint will enlarge from some of these mobile communicators, so that we in those outlying areas, Neleni and some of those other areas that is out there in the real rural areas, would be able to have touch points in that. So I'm not saying it's going to happen today or next week or next month, but Inam, it is there. They actually have it. They have a plan to be able to do that. As you know, it's for 17 years that government actually held the spectrum close to its chest and didn't want to release it. It actually took court orders and threats, etc., and long discussions until Minister of Communication and the presidency and the government decided to release the spectrum and allow those other providers, Cell C, MTN, Vodacom, Liquid, etc., to actually buy, auction, and bid for it to do that. So it will get there. It will get there. So now you spoke about something that is very important. I think there's one area that I just maybe want to refer to lastly, and that's around the shaping of how the regulatory, sometimes it's important to acknowledge that some of our stakeholders is the government. And there's a regulatory environment that will shape the business practice in every sector. As in most other countries, in healthcare and health technology, South Africa is a subject of high levels of regulation and intervention. And I have a list here of 1, 2, 3, 4, 5, 6 regulatory factors or practices that we have to take into effect before we can even think about, our healthcare technology or technology in healthcare market. The first one is the Medicines and Related Substance Council Act, 101 of 1965. As amended, it regulates the sale and distribution of medicines, as well as medical devices and technologies, which are broadly defined in the Act to include simple and complex devices. So we have And that obviously is important to have it, because the purpose of that act is to do the regulation of all distribution of medicines and medical devices and technology. It's called the Medicines and Related Substances Control Act 101 of 1965. It's still in place.
Sorry, Rod, 1965, no revision, nothing.
It's amended, as amended. I
Oh,
said
as amended.
1965 as amended,
Okay.
as amended.
Okay.
Obviously, it's been
Okay.
improved over a
Okay.
period of time. It regulates
I
the
hope.
sale and distribution of medicines, as well as medical devices and technologies. The second one is the Health Professionals Council of South Africa, HPCSA. That is the statutory body tasked with protecting the public and guiding professionals. Many of the guidelines in HPCSA have come to some form of criticism lately, mostly notable by the Health Market Inquiry, in regard to the restrictions of fee sharing, multidisciplinary group practices, and the employment of doctors. So the HMI conclude that HPSI's guidelines in these areas has significantly inhibited the evolution and the innovative and integrated models of care. Let me say that again, because I think we need to grab that. The Health Professional Councils of South Africa is a statutory body tasked with protecting the public and guiding professionals. They've come under criticism, most notably by the Health Market Inquiry, and this is in restrictions on fee sharing, multidisciplinary group practices, and the employment of doctors. That's the second one. The third one is the Medical Schemes Act 131 of 1998. This regulates the way in which a scheme operates, the value of reserves a scheme should hold, and the cover provided by the schemes, including setting that very big thing that we always hear whenever we register for medical aid, your prescribed minimum benefits, the set of diagnosis, treatment, combinations that must be reimbursed by the schemes. So the Medical Aid Schemes Amendment Bill that was introduced in June 2018 seeks to fundamentally alter the role of schemes in light of government's plan for the NHI program. So you can see the effect that the NHI program will have. So the Medical Aid Schemes Act 131 of 1998 will actually look at altering the schemes in light of government's plan for NHI. The fourth one is what we call the Council of Medical Schemes, CMS. They provide regulatory supervision for private health financing schemes and reports annually on scheme expenditure and other metrics. So the council's mandate includes protecting and informing the public in respect of medical schemes and making sure that complaints are handled appropriately, ensuring compliance with the Medical Schemes Act, and improving the management and governance of medical schemes. So that is actually our advocate. You and I, the consumers, the one that goes in for this medical aid, the Council of Medical Scheme makes sure that the medical aid schemes, they act in a certain way of providing the right, they're handling the complaints appropriately and making sure that Medical Schemes Act are improving the management and governance of the medical schemes. The second last one that I want to talk about, and obviously this one is being revised time and time again, is the protection of personal information. You know, there's the lawyer and client relationship. There's also the doctor-client, the protection of personal information. The POPI Act 4 of 2003 and the amended one regulates the protection of personal information that is processed by both private and public bodies. The Act set up minimum requirements with which businesses must comply when processing personal information. It's similar to what they have in Europe. It's called the GDPR, the General Data Protection Regulation. So given the high sensitivity and the nature of health data, there are specific protections that relate to biometric data as well. And lastly, whether we like it or not, it is there. It's the broad-based Black economic empowerment. It's a legislative framework that primary purpose of which is to address the legacy of apartheid and promote the economic participation of previously disadvantaged groups in South Africa. So all firms wishing to supply products and services to the public sector must provide that triple BEE certificate. And it's there. I'm not saying it's working. I'm not saying it didn't work, but it is there. And you have to comply with that. I'm going to pause there for a moment.
I had hoped that you won't cover that one.
Unfortunately, it is there.
No. You know that Transnet official has removed triple BE on their tenders?
I'm sure a lot of companies will start doing that. But what I'm saying is, it is still there. And there's a group of attorneys that actually explained, I'm not going to give some free advertising to some attorney group, but there's a group of attorneys, attorney firm that actually gave the unpacking of how the triple BE codes are being explained. And you can actually have a look at that.
Yes, but the thing is, what I'm saying to you is, if government consolidates the environment for procuring for government and
Mm-hmm.
and triple BE has been removed,
Yeah,
African companies are not going to benefit.
absolutely. Absolutely.
So those are the issues that I think right now needs to be addressed
Mm-hmm.
in addressing this big elephant. I think personally, government needs to do better for the rural and peri-rural areas. People in those environments, they deserve better. And you've said which areas that needs technology, but there's basic technology that is not that is not there in the rural areas
Mm-hmm.
or small
Exactly.
dorpies or small. What do we do? Because what you see, the big companies, OEMs, the ones that you've mentioned, and I'm not going to mention them because people then are going to say I'm attacking them. Um, they will only spend where they will benefit more.
Mm-hmm. Okay,
We
I hear you.
need to have a system in our country where we're pushing all the OEMs and technology companies, including government themselves, to go service the peri-urban and peri-rural areas. Some doctors that I had an interview with the other day, they say to me, people always talk about smart city. Let's not start from the top. Let's say smart village, then smart township, then smart city.
Absolutely. I like
Okay?
that. Smart
So,
village,
so smart
say,
township and
smart
smart
township,
city.
then smart city.
Right?
Okay, I get it.
So that means we do smart health sector in the villages, then bring it to the township, then bring it to the urban areas. Urban areas have got it all anyway. Okay? They've got it.
Okay.
Sentins of this world, centurions of this world, forwards of this world, they've got this technology already.
Yes.
So government must leave these areas and stop focusing on things. Before smart city, you need smart health.
Yes.
You know,
Yes.
so let's go smart health in the villages. At least before they become smart villages, they become smart health.
Exactly. I'm
We
with you.
preserve
I'm with you.
people's lives. We preserve people's lives, or we ensure that mortality is reduced, and basic services are offered. Then we move on. Then um, we then in 10 years time or 20 years time we get to the urban areas. They will be far ahead anyway, because there's people that are working, there's economy that is pumping. In the rural
Mhm.
areas there's no economy.
Yeah, that's true. I think we're running, we're nearly exhausted our time, Sonabo. It was a very interesting subject. It's obviously something that's near and dear to everybody's heart. It's around health. And, if you look at what the World Health Organization actually put through is to say that we need to make sure that we actually, and in some instances, it's a constitutional right, such as in South Africa, where it's a provision to actually look at healthcare, to actually make sure that your
Okay?
citizens actually have a proper
Mm.
health care. It's like water, or it's like some of those other aspects that is important, and it's enshrined in our constitution to be able to provide a roadmap where our people can actually benefit out of that. I know that I spoke quite a bit. It was quite an exhausting and a long discussion, because we covered most of the aspects that regards to health technology. But I think it is available if anybody would like to actually read. There's a paper, there's a peer review paper review that I actually wrote with regards to this. It's available. If you're interested in that, you can please engage with Paita. Paita's email. So Nabo, when he closes off, he'll actually just give you the email address and tell you where you can actually get that. I will share that with him, and you can actually have a look at that. It's good reading. It's about eight or 9 pages. It's a very, very useful document. It obviously has got all the references related to that, and you can actually get some benefit out of that. So thank you so much, Sonabo. It was great being on the show. It was fantastic, and I'm going to leave the last word over to you.
Before you leave, Rod, thank you very much for making it and for always appearing and supporting the platform. But I need to leave this with you. I need, emerging technologies in the health sector. Yes, you've talked about technology in passing. Maybe you need to invite organizations like Software AG to come and talk about emerging technologies.
Absolutely. Absolutely.
Okay?
That's a good idea. Not only
And
Software AG, there are plenty. There's AWS, there's
no,
software.
I'm making example. I'm making
Of
example.
course.
AWS, now that you've mentioned them, IBM, now that you've mentioned them, and see what can we hear from them in specifics. And when we interrogate and having a discussion and interrogate the discussion, maybe also make them commit on what they need to do or what they are doing. Maybe we don't know they're doing something in the rural areas. Okay.
Absolutely. Absolutely. That's a
It
promise.
is
I will reach out to some of those multinationals, and I will bring them onto this platform and afford them the opportunity to share what is it they're doing. There's another aspect that obviously that is much bigger than this. I'm sure they are actively involved in the corporate social responsibilities, such as clinics or healthcare or some form. I'm sure they're very active in that, but I think it needs to be highlighted. And this is the platform where they can actually share and tell us what is it they're doing. But I will take that as an instruction from you.
Thank you. For me, I wouldn't be doing justice if we don't address such issues. PICA exists to ensure that we try and close this technology gap that exists, digital gap, coverage gap, and as you think, all other types of gaps that are there. We need to close that. We need to assist or we need to address how they need to be closed. Without us addressing such pertinent issues, then we would not be delivering the mandate of PICTA, and this platform exists to support the mandate of PICTA. Okay. And we did not touch today what we do to ensure that these youngsters based in everywhere in South Africa are exposed to this technology so that they can be, motivated to be able to come up with innovative ideas on coming up with solutions to address, pressing challenges in our communities, and stop spending 300s and 400s of billions bringing technology into the country.
Exactly. Agree with
I
you.
think, Rod, thank you very much. And if people want to engage with PICTA via email, it's PICTA at picta.africa, picta at picta.africa. We are available in all social media. If you contact us through the social media, Facebook, Instagram, Twitter, LinkedIn, will be able to respond to you guys anytime. We are mostly very active in those platforms. We'll 24 hours would have got your response, and 24 hours you'll have your response on your email. But we are always available to engage. We are looking forward in having these discussions or robust discussions as we go into the future. We exist because communities exist. Without communities, we don't exist. We need to address or assist or enable or advocate for the change of our communities or challenges in our communities. Thank you, Rodney. Thank you very
Thank you
much.
so much.
I
Much
appreciate, and I
appreciated.
must thank everyone who is troubled herself or himself to come and listen, and to those people who are going to take time to watch the video post this session. Thank you very much. Till tomorrow.
Thank you very much. Bye-bye.
Goodbye. Goodbye.